I just want to talk about some of this stuff that's happening with medical supplies and supply chain stuff and products that may or may not be real. And I want to also go over three cases that I feel like if I give you guys some clinical information, some like interesting cases and some key points, some key takeaway points, then it might be really helpful for you. Because these three cases I'm going to present to you were all presented to me, when they asked my help on them by, experienced people that I consider very good injectors, very thoughtful people, but yet, things happen and sometimes it's hard to understand the anatomy or what's actually happening. So I think these three cases will really be interesting for you to hear. But I want to start off tonight by just talking about products. I want to talk about a concept that if something seems too good to be true, it usually is. Janet Lynn Montgomery. Hello, everybody. And what I mean by that, right now, I don't know what your practices are like, but we're experiencing a shortage of like almost every medical product that we try to get. I mean, we're short of, saline. Like we can't get saline. How can you not get saline? It's salt water. We can't get it. Xylocaine, gloves, caps, gowns, booties, drugs for anesthesia, antibiotics. We can't get them. I mean, they are on tremendous back order, and there's all kinds of reasons. We don't even ask anymore because it's sort of like supply chain, manufacturing issues, shipping. It doesn't matter. No one really knows. But what I do know is that you can get it if you're willing to pay like 20 times more than it's worth. Like something that we used to pay $1 for, now they want us to pay like $50 or $70 for. And it's insane. So it's sort of like, hey, there she is. I've been wondering where Val was. With these incredible shortages going on, people are taking the opportunity to just gouge providers, so we, do our best, but sometimes we have to bite the bullet and pay, 10 times what we ordinarily would pay just so we don't have to cancel a surgery. I mean, it's gotten to that point. So in this sort of atmosphere of people sort of like slowing down things and decreasing supply, demand is increasing, right? There's still a lot of people looking for aesthetics. So, supply right now is nowhere close to keeping up with demand. So what happens with prices? Prices go one direction. They keep going up. So, sometimes you just feel like you're being taken advantage of for basic things like saline and lidocaine. Like, what does it take to make saline or lidocaine? I can make it myself. Like, but what's the problem, right? So we're trying to get vitamin water and snacks for the staff. Can't get them. They ship 3 weeks later. You're like, it's a bottle of vitamin water. I'm like, what is happening? The world's upside down. So compare and contrast that with, let's say, medical products. Let's say you want Botox. Let's say you want Juvederm. Let's say you want Restylane. Let's say you want Skin Medical. How long is the wait for that? There isn't any. You can get it next day. Like, even in the depths of COVID or some of the, medical and economic problems we've been going through, we never had to wait for Botox, Juvederm, Galderma products, just anything, right? We can get it the next day. So there's no supply chain problem there. There's no shipping problem there. There's no manufacturing problem there. There's no worker problem there. But pretty much everything else in the world is affected by that. Don't you find that interesting? So, in light of all this that's happening, all of a sudden, you get these faxes, these texts, these emails saying, we have discount products for you. Where everyone else is paying 100 times what these products are worth. Hello. Hey, Kristen. All of a sudden, you can get reduced price Botox. You can get discount Juvederm. You can get discount Dysport. You can get discount. Wait. How come every other single thing I want, I can't get? I have to wait like 3 weeks to a month for it, and it's 100 times the price I usually pay. But now you're offering me these same products. We know that everyone in the country has to pay the same price for Botox, right? $631 or whatever it is. But you can get it from this company somewhere for $400. Does something not seem right about that? Does it seem too good to be true? I think it probably is, right? So what's going on here? Well, right, everyone's creating a supply problem, a long delay in shipping, and then when you finally get it, you pay through the nose for it, right? So why, when everyone is set to pay higher prices and everyone's used to being gouged and everyone's just like giving up, fighting, you're getting all these text, emails, faxes about discount products, discount Juvederm, discount Botox, discount everything? Is it raising any red flags yet? Does anyone think that this is a reasonable thing to do to purchase these things? Yeah, Val says scam artists. More than that, really. Yes, you're right. They are scam artists because you have no idea what these products are. If you're not buying them from the company, you don't. We actually had this happen to one of the members of our network, and we looked at the, hey, Charles and Maverick, nice to talk with you tonight. We looked at the lot number of the product, and we found that the product was shipped from South America and another one from South Africa. So, hey, Saitan, good to talk with you. So here we are in the middle of this world where we can't get any products without paying through the nose. We can't get saline, we can't get gloves, we can't get gowns, we can't get sterile water, we can't get vitamin, we can't get anything. And when we do get it, we're paying 50 to 100 times what it's worth. But now we're getting faxes and emails and texts saying, hey, we can give you discounted Botox. We can give you discounted Juvederm. We can give you discounted everything. So in my mind, the big red flag is waving. And it means to me that, yeah, Aesthetic Nurse Jen says junk product, fake product, right? So unknown safety profile. Absolutely right. So when you're ordering product from anywhere other than the manufacturer, you don't know what you're getting. And unfortunately, these products are not FDA approved. And as I believe most of you know, if you inject a non-FDA approved product into a patient, that's a felony, right? That's a crime. That's just think about how hard you've worked to get where you are, how much time and money and effort you've spent, time away from your family, late nights in the office, whatever. We've all been there, right? And you're all of a sudden going to jeopardize that for saving a few $100s on a product that's probably going to put you in jail if something goes wrong, if someone finds out. So whenever you get one of these notices or offers, I mean, I'm sort of giving it more credit than it's worth. I would immediately contact the company, right, the rep or the regional manager of that company, and just send them, hey, Cassie, would never risk it just to pay a little less. 100% right. None of us should ever risk any of this stuff, particularly since we don't know what it is, and we don't want to inject it into a live human being, right? Because it might, do something terrible to them. You don't know what's in it. So, so you just send that document to the regional manager or the BDM rep from that company, and they will aggressively pursue these companies. Usually, they will prosecute them and just don't get involved. And it's called a gray market. It happens every day. It's like whack-a-mole. As soon as one pops up, and they go after that one, then another one pops up, and another one pops up. But if no one's buying it, then they go out of business, right? So just be strong and realize that this is a scam, and it's a dangerous scam, and it risks everything you've been working all these years to build. A fast track to failure. That's right, Aesthetic Nurse Jen. Hey, Kate, good to talk with you. Good. We've got to talk about something that you DM'd me about last week. So, Kate, I was just saying, how in this time where we're experiencing shortages of everything and can't get any products and supplies without paying through the nose, people are getting these things for discount, products of Juvederm, Botox, Dysport, whatever, and we know it's fake, we know it's dangerous, we know they're not FDA approved, and we know that you can get into big trouble if you use it. So we're just saying send those documents to the company. They will pursue those fake companies and hopefully keep people safe. That's what this is all about. So I just wanted to get that off my chest and just sort of make sure everyone understands that this can be a really serious felony and people will lose their license and their practice and everything. So, but I wanted to present 3 patients to you tonight that members of my network brought to my attention. And these are all injectors that I really respect, that I really enjoy working with, that are excellent injectors. But no matter who you are, sometimes you run across, cases that are difficult or don't go exactly the way you planned. And hopefully you have someone you can reach out to, like the Aesthetic Mentor Group, and we're happy to help you. Hello, Maria. Been waiting. Your boss joined a little while ago. Hey, Bliss. Kristen. Christine. So, first case, 40-year-old woman comes in for Botox. Don't think she'd been treated before. Has sort of a weakish looking forehead, not a lot of activity when she raises her eyebrows. Has a moderate activity in her glabella and crow's feet as well. Gets treated with, small dose in the forehead, maybe 10 units, maybe 20 units or something in the glabella, maybe 5 or 10 on each crow's feet. And 5 or so days later, she calls the nurse and says, my brows seem really heavy and I've got extra skin on my eyes and it just doesn't seem right. So one of the nurses sees the patient and says, well, I think that the forehead neurotoxin kicked in a little bit sooner than the glabella, and so she gives the patient more Botox in the glabella and the lateral brow to create, sort of a brow lift. No improvement. In fact, the patient calls back and says, now I've got 4 eyelids, I got a double eyelid on both sides, and I'm much worse and I'm, really unhappy. So we look back through the case to try to figure out, what's going on. Well, does anyone have any idea what's going on? Does anyone have any idea how 10 units in the forehead, and they were given high, from what I understand, above the midline, it's 10 units, and the patient seems to have a terrible, kind of brow ptosis. And if you look at her post-treatment photos, a couple weeks later, she really does have 4 double eyelids on each side, and the skin is kind of resting on her lashes, and it looks terrible. And so the first clue I gave you was that she didn't have any forehead lines at rest, and when she animated, yeah, exactly right. Nurse Jen, you're going to have to be doing these aesthetic mentors for me because you're right on top of it. Yeah, so she had a weak frontalis, meaning that it was probably very sensitive to neurotoxin. Maybe the 10, even though, she stayed high, maybe the 10 was too high dose. Injecting mist says too lateral. She said she purposely didn't go lateral because she was trying to create a little bit of a Spock brow to help raise the patient's brow. But when we looked at the pre-treatment photo, now, if you look at an aesthetically pleasing woman and you look at her orbital rims, where should the eyebrow be relative to the orbital rim at its highest point? And we know the highest point is right at the lateral limbus. So where should that eyebrow be? Does she have heavy hooded lids? Yeah, she kind of did have some hooding preoperative or pre-treatment. Why treat it if it didn't move? Well, I'm not going to say it didn't move, but it didn't move with the same amount of activity that the other areas did. So some people just have weak foreheads, right? So she did what she thought was a reasonably conservative dose, and she did it high so she maintained lower frontalis function, so she didn't get brow ptosis, but yet she still did. So when we looked back, now back to my question, how far above the orbital rim should the brow be in a normal aesthetically pleasing woman's eyebrow? Anybody? Injecting mist knows this one. So it should be about 1 centimeter above the orbital rim. And in a man, here's my orbital rim. In mine, it's right at the orbital rim, and it's pretty straight across, which is normal for a man. But in a woman, you want a good centimeter of separation from the orbital rim. And if you look back, not 1 to 2, 1 centimeter, maybe a little bit more. Some of the lateral glabellar dose slipped in. She didn't give the lateral glabellar dose. I don't know. These are pretty good injectors who are very experienced. So although it's possible that they did hit some of the frontalis, if they didn't go deep enough, because the glabella, you have to go through the frontalis to get to the glabellar muscles. Sorry, I'm listening to my husband. Okay, no, don't worry about it. I know you know this stuff. So sort of a weakish glabella, but when you looked at it, you can see that in her preoperative or pre-treatment photo, her eyebrow was more than 1 centimeter above the orbital rim. It was maybe 1.5 centimeters, maybe even more. I wasn't there to measure. I'm just going by the photos. But I can tell you it was already very high and she already had some skin excess right here. So here this patient is trying really hard to raise her eyebrows to get rid of that extra skin here, right? So her eyebrows in this resting position were too high. Her frontalis was working as hard as it could, even though it was kind of weak. It was working as hard as it could to keep those brows up. And with a little bit of neurotoxin, the brow dropped to a normal position, and she had really severe excess skin of the upper eyelid. So it was kind of interesting. So what's the take-home message from this case, right? Because the bottom line for me, well, I'll see what everyone else has to say. So what's the what do you learn from this case about a patient like this next time you see them so this doesn't happen? So the combination of a relatively weak frontalis with a patient sort of overcompensating to raise her eyebrows to an over-elevated position who still has excess skin of the upper eyelid. Do you see where I'm headed with this? Right? So do a good pre-treatment assessment. So if you were doing, you wouldn't treat the frontalis. Yeah, that's actually the take-home message. Because if you already have extra skin and you're trying as hard as you can to raise your brow to really an overcorrected position and you still have excess skin, what do you think is going to happen even when you give us some, yeah, you're right, acoustic tap blepharoplasty. So when you just lower that frontalis, the brow a little bit, you're really going to accentuate that. And that person needs a blepharoplasty, right? She needed a blepharoplasty. And if you were going to treat that patient, you're right, you probably should just not have touched the frontalis, because you can always go back and give some if you really think they need it later, but just release all the depressors, right? Maybe even do the lateral brow to sort of give the patient some additional lateral brow lift. But I think you have to have the talk before you do anything and say, you know what, you really need a brow. So you really need a blepharoplasty, because no matter what we do to you, you're going to have extra skin, and if your brow even comes down a millimeter or two, it's going to look like you're 100 years old, and that's exactly what happened, right? So when you're doing your pre-treatment assessment, have the patient animate and see what kind of activity they have in the frontalis, and if it's kind of weak, that's okay, but always look at the position of the brow, right? If the person's brow is low and you haven't treated them, you know that they don't have a lot of frontalis function. So you really want to be careful with that patient and probably not to treat the frontalis and treat the depressors really aggressively, right? If the patient has excess skin sitting on the upper eyelid and their brows in a normal position, then many students ask why we stay in the goalpost or why we cannot go out a little, because the frontalis and lid space can be complex. And it's a lot. It's too much information at the intro level. You're 100% right. And this is kind of someone who's one of our best injectors. And it's just like, unless you're really thinking about it, or if you have this kind of complication, it's okay. But the question is, what have you learned from it, right? And from this case, we've learned that someone with a weak frontalis, with an overcompensating brow, with pre-existing excess skin of the upper eyelid is a setup for this exact kind of ptosis problem, where you've got, like, she literally has 4 eyelids, 2 double eyelids on each side. So it's better to do that analysis. Always look at brow position, always look at relative strength of the frontalis, and look at the excess, if there is any skin of the upper lid, and put all those 3 things together and come up with your assessment. And it's fine to say, hey, listen, you don't have a very strong frontalis. You may have a little bit of wrinkling, but I think we should stay away from that for now and just treat the depressors to get that brow lifted a little bit. And then see what happens. You can always, as long as you share that information, upneak drops, I think it's the same as what we've been using with the other alpha adrenergic agents. I think they, I think what the right word is, neosynephrine, or I can't think of the other ones. But they're all the alpha adrenergic stimulants of the upper eyelid are the same. It's just a temporary. It stimulates the Mueller's muscle, so get a little bit of elevation for lid ptosis. But we're not talking about lid ptosis here. We're talking about brow, right? We're talking about brow position. But the drops are fine. I mean, some people use them for complications. Other people use them if you have a little bit of senile ptosis and you don't want to have an operation. They work, but they're temporary. But anyway, always analyze the frontalis and say to the patient, look, you have a kind of a weak frontalis. I don't want to treat it because I'm afraid you might get a brow droop. Let's see you back in 2 weeks. If it's fine and everything's okay, we can do it. But you'll be kicking yourself in the pants if you treat someone like that and what I just talked about happens to you when it was totally avoidable. So remember, look at the brow function, look at the elevation of the frontalis, look at the position of the brow relative to the orbital rim. It should be about 1 centimeter above the orbital rim, and look at any excess skin of the upper eyelid. If they've got that, they're a brow candidate. They're a bleph candidate. Second case, patient comes in to one of our really good injectors and says, I want to treat my forehead, my glabella, and crow's feet with Botox. Injector says, I think you need a little filler in your cheeks too, so they do some Botox here, Botox around the crow's feet, and they do some cheek filler. Patient sort of says right away, I don't know, it feels like it's a little stiff, in my cheeks. I don't feel like they're moving normally. And, the injector says, well, yeah, because I just put filler in, it's all going to go away, blah, blah, blah. 2 days later, the patient says, my face is not moving correctly. I'm having, it just feels like one side is much stiffer than the other. And the injector's like, well, I think it's just, it's going to get better. The product will soften up, and blah, blah, blah. 5 days later, the patient says, when I smile, one side of my face hardly moves. What happened here? I'll give you a hint. It wasn't from the filler. Aesthetic Nurse Jen, you're going to be teaching courses for us. You understand that, right? You're getting every single... the tox migrated, zygomatic is major and minor, right? So when you're injecting the anything around the orbital rim, you want to stay 1 centimeter back from the rim because you don't want anything to migrate into the eye, into the orbit. I've seen that happen. And then you have the intraocular muscles, and you have affected, and you have diplopia, which is horrible. Fillers sitting on a nerve. No. Did the injections here, went a little too far away from the orbital rim and a little too deep. So Val, what's below the orbicularis oculi muscle that's just a little bit lateral and a little bit deep? It's the zygomaticus major and minor, right? Because it goes from the corner of your mouth up to your zygomatic arch, and there's some overlap with the orbicularis, right? So it goes like this. So if you go a little too deep here or a little too lateral there, I've done it once too, you can hit the zygomatic, you can hit the zygomaticus major and minor, and it really interferes with the way you smile. So this injector thought it was just from the filler, and then when we sort of looked at it, we were like, wait, she had a normal smile initially. Now she smiles and she's like, this side just stays down, this side goes up, this side stays down. So that can happen. So here again, it's all about knowing the anatomy, right? Knowing that you have to be really superficial here, because when you pull the skin of your lower eyelid, you're not just pulling skin, you're pulling skin and the orbicularis oculi muscle. That's how thin it is, right? So if you're not raising a bleb in your injections, you're generally going too deep. And if you go even just a few millimeters too deep, the zygomaticus major and minor are literally right there. So that was a lesson to be learned. So the lesson here is make sure you know where the orbital rim is. Don't go more than 1 centimeter, off the rim. You have to follow the course of the rim. Your rim doesn't go this way; it goes this way. So you might just mark it. How many units did she use? I don't. She's I don't know, 10, 15. I don't know exactly, but it wasn't an excessive amount. I don't remember. It's really not about the dose. It's about the depth and about the distance away from the orbital rim, because the zygomaticus major is right underneath the orbicularis oculi muscle. There's a little bit of fat. So that's the other thing I wanted to talk about. In thin patients, you have, would you leave it or try to relax the other side? I'd ask the patient, but I don't want to create another problem for the patient, because, presumably this will wear out pretty quickly, but I don't like to make the other stuff so she can't smile at all. But if you have a patient who's very thin and this patient was thin, they're much more like most dangerous patient you'll treat is the old thin woman, right? Because the older patients have less fat, and when they're thin to start with and they get even thinner, there's like no separation between the muscles. There's no separation around the nerves. Fat is your great like shock absorber, but it's your great protector. It separates layers. It separates the muscles. It separates the nerves and the vessels are all covered by fat. So in a thin patient, you just have much less margin for error. The toxin can migrate. Your filler shows more easily. All these. It's just they're more complicated patients. So that was case 2. Here's case 3. Again, these are all really good experienced injectors, but can just a few units that may have gone too deep? Yeah, absolutely. You don't need much. The zygomaticus major minor are very small muscles. They're very thin muscles, and even just a few units will affect it. Absolutely. Yeah. I mean, if you're in the right plane, if you're in that superficial plane between remember, the lower eyelid and the area around the eyelid is the only place where you have no subcutaneous fat. The muscle and the skin are directly attached to each other. That's why it wrinkles so easily. So if you go just through what you think is skin, you're actually gone through the orbicularis muscle and you're right into zygomaticus, or pretty close to it, right? So you have to be particularly meticulous about being superficial here, and you have to raise a bleb and stay close to the rim. So, case 3. Nurses doing jawline chin enhancement using Voluma and some velour. So she's doing an enhancement to make the angle of the mandible more visible, and then she's treating some of the areas in the pre-jalous sulcus. And she goes in, she's injecting on bone, and she comes over here, and she goes down on bone. She's going down on bone, and the patient, just screams in pain, and the nurse just pulls the needle out. And within a very short period of time, the patient says, "I can't move my mouth right. I feel like that side of my mouth is not moving. What happened? What happened?" It was immediate. And the nurse never injected any product because she was nervous. Yeah. Injecting this has it right. Mental frame and struck a nerve inflammation. Yeah, so she went in and she went right into the mental frame, and the mental nerve artery and vein come right out there. So she went right into the nerve. And had an immediate palsy. So she called me and asked me what to do. What would you tell her? Yeah, Lucy, nerve is right. Ouch. Big ouch. And it was her sister. So I guess, if you have to hurt somebody, maybe someone that's not going to sue you is good. But yeah, so what are you going to tell her? Like, what's going to happen? It will get better. Yeah, I mean, there really is nothing you can do. I mean, presumably the needles are pretty small, right? You're using probably, 27, 20, 30, something like that. And, you can hit the nerve and injure it. And as you know, nerves can't take a joke. They heal very, very slowly, if at all. But since it's, presumably just a single stick injury and it's a small, caliber needle, it will get better. And I said, there's nothing. What I did tell her to do is to get a muscle stim, device to keep the muscle from atrophying, because you don't know how long it's going to be knocked out. But I followed up with her about a week or so later, and she said it was already getting a little bit better, right? So when she smiled, the normal side went down, and the abnormal side didn't go down, right? Because these are all your depressors, the DAO, the Mentalist, and your DAO. So, and your DLI. So this is the normal side, and this is the bad side. And eventually this side started to come down a little bit. So I said, that was very encouraging. that in a relatively short period of time you've already gotten some of the function back. I thinking about this, I have to call her again because it's been about a month or so since this happened. I'm going to follow up and see how she's doing. So what's the take home here? What do you think is the take home message here to prevent this from happening again? What would you advise this person, or really any person, to do if they had this kind of thing happen to them? Because we know where things are for the most part, right? We know where the mental foramen is. We know where the infraorbital foramen is. We know where the supraorbital foramen is. We know where the nerves come out. We know where the vessels are. Take a cadaver course, 100%. 100%, because you're saying that you're only as good an injector as you are an anatomist, right? So, but let's say that we all have taken a cadaver course, and again, you should never take just one cadaver course, because the more you take, the better. The more you know, the more you're going to take away from the course, and so I suggest doing it every year or two. You'll be amazed at how much you learn each time. But here to me the key is this: that even if you know the anatomy, once you start injecting, you're not thinking about anatomy anymore. You're thinking about that deformity that needs to be filled, right? And as you inject certain areas, you might create sort of a more, another deformity in another area that you hadn't seen before. So once you're in that injecting mode, you're just going after whatever, deformity or, volume loss area that you're seeing. So I think the take-home message here is that you should mark out the relevant anatomy. Like when you're near the masseter, mark the facial artery out. Mark the superior and inferior labial arteries out. And in this case, mark the mental foramen. Just put an X over it so that when you're actually injecting, you're like, oh, yeah, right, there's a nerve under there. There's an artery under there. There's some, because if you're just chasing whatever you're chasing, you're putting the anatomy aside, right? So certainly when I first started, I marked every single patient. Right, I marked every single Botox injection point because I thought, like, once I start injecting, I'm not thinking about anatomy anymore. Let me do the assessment. Let me mark out the relevant anatomy, right? Let me put an X on that mental nerve so I don't hit it again. Let me put an X over the facial artery so I don't actually, go down the bone and go right through the facial artery and have a terrible problem in my hands. So mark out the anatomy. Do all your planning in terms. I even draw like where I'm going to inject. I even draw the lines I'm going to inject on. So that like once I'm in the injecting mode, I've done the artistry, I've done the evaluation, I've done the dosing, I've done the pattern. Now I just have to execute it. It just becomes a technical exercise, right? Because I don't want to be thinking and moving and wondering about things when I'm trying to inject. I really want to focus on being the best technical injector as I can. And I can see, it's like being on a highway with no signs. Like you don't know where you're going. But at least if you say, exit 5 is 2 miles away, you're like thinking, okay, I can't keep driving. I got to stop and focus on this exit that's 2 miles away. Just like when you're injecting in that area, if she had marked it, she would have been like, oh, well, I've got to be careful not to go into the mental foramen. I've got to, just be aware that it's there. So I have to adjust my injection so I'm a little lower, a little higher, come at a different angle, whatever it is, right? Whatever it is. So I think that was the take-home point that I said to her, like, just mark out the anatomy. So you've done that, and then just focus on the technical aspects of injecting, and then everyone will be safer and better. And it takes a little bit longer, but honestly, I still do it every single day. And this is my 31st year in practice. And I just find that it clears my mind. Like, let me do all the thinking and planning first, and then I just execute, right? And I could because that's kind of the way it is with surgery. Like, you've got your plan, you've got everything ready, and you just do it, and you do it the same way every time, so you don't forget any steps, you don't, leave anything out. And that way you become comfortable, and you just it becomes a routine for you, rather than saying, I think I'm just going to jab a little there, and you're like, shit, that was the problem. And I knew that anatomy. I shouldn't have done that. So anyway, those were the 3 cases that I wanted to present to you tonight, in addition to talking about the problem with products, fake products that can get you guys in big trouble. So if there are any questions, I'll be happy to take them now, but I don't really have anything else to say. Jen Walsh. Yeah, I think the case studies are fun too, and Jen, you knew every single one of them. And I think you're going to have to do an aesthetic mental for me. Will you do that? Will you do something like that for me? I always try to present interesting cases because almost no matter what the topic is that I'm talking about, if I have an interesting case, I like to share it because I think that's where the real learning comes in. And these are kind of complex cases. Like if you don't really understand the anatomy and how things interact, and elevators and depressors in the first case, in the second case, just understanding how the muscles are aligned and overlap each other. Oh, thank you. You're welcome. I will have more. And also, if you guys have interesting cases, I'm happy to present them as well and talk about it. Because that's really where where the rubber hits the road, right? We can all talk about it. But it's really from these complications, these problems, that most of this learning occurs, because anyone can just inject the average patient, not think twice about it. But when you have one of these kinds of complications tonight, where there are lots of moving parts, right? Particularly in that first case, I think it's surprisingly to me, good patient case on MA Facebook today. Oh, thank you. I'll go check that out. But when you have something like this, it forces you to go back and say, okay, like, what am I learning from this case? How do I stop this from happening again? And like, what did I miss? And if you don't know, I'm happy to help you guys. You're welcome, Elise. Thank you for joining. I hope this was fun for you, even though you're not an injector. I hope you enjoyed listening to some of the discussion. Thank you for joining. So that's it. Just take these messages to heart and sort of try to learn from them, because no matter who you are, you're going to run across a problem someday and be like, geez, this is tough. And hopefully you'll have a mentor or someone there that can help you, or you can bring it to us on an IG Live, and we'll help you. So anyway, until next week, have a great week. It's been a lot of fun. I enjoy the discussion, and I enjoy hearing the answers, and I like it being interactive. So have a great week, everybody, and we'll see you next time. Bye.